Bismillahirrahmanirrahim. Assalamu alaikum. My name is Munazza Naveed. My roll number is BP1650154 and I'm from 5th year morning. The topic of my presentation is essential drugs knowledge for pharmacists, including rational and irrational drug use. And the drug which is assigned to me is Emtricitabine with Tenofovir. The fast discovery and development of combination of antiretroviral agents results in the long-term control of HIV replication. Amtricitabine is often co-administered with tenofovir and once daily fixed combinations available with or without efavirenz. As we know, tenofovir and amtricitabine is an antiviral therapy active against HIV and hepatitis B virus, so we must know about hepatitis B and HIV first. Hepatitis B is an infection which affects the liver, leading to damage to hepatocytes, resulting cirrhosis, cancer, and finally death. Chronic hepatitis B infection is treated by antivirals. Now, what is HIV? The causative agent is retrovirus, which enters via mucosal surface of blood into the body. It binds to CD4 plus T cells and cause damage, and it further spreads into the bloodstream and cause further complications. Here are the following stages of HIV. The acute HIV stage is also known as initial stage, in which the flu-like symptoms appear that occur days to weeks after HIV infection. This stage further progresses into chronic HIV stage, which is also known as latent or asymptomatic stage. It can last for several years. Symptomatic stage appears in which the symptoms of HIV infection appears. Lastly, the AIDS occurs when CD4 cell count falls below 200 cells per millimeter cube, which makes a person vulnerable to opportunistic infections. Now here is the classification of antiretroviral drugs for HIV. There are five main classes: nucleoside reverse transcriptase inhibitors and an RTIs. The third one is protease inhibitors, then the entry inhibitors, and lastly the integrase inhibitors. Here are the following drugs as under prescribed. There are some drugs which for the use for the prevention of vertical transmission, that is from mother to child during pregnancy. Uh, for the children, the drugs has been prescribed for HIV positive, and for post-exposure prophylaxis means the person has been exposed to recently exposed to the HIV infection, and within 48 to 72 hours he has been started with the drugs to prevent the infection or the progression of the disease. For pre-exposure prophylaxis means the person is at risk of HIV infection and he has been on the medications to prevent the infection. Now here are the combination drugs as well for the approved for the adult use as well as approved for the pediatric use. Among these, zidovudine and lamivudine. Lamivudine is one of the most commonly prescribed combination drug in common practices. Among these, tenofovir plus amtricitabine is also very commonly used combination with or without efavirenz. It has been recommended that if the CD4 plus cell counts are below 200 per microliter, zidovudine is a drug of choice for the initial treatment of symptomatic children or individuals infected with HIV and to prevent mother to child spread during birth. Several of the drugs may be combined into one single tablet to make it easier to take your medications known as antiretroviral therapy. It further increases the patient compliance as he is in the following drugs. He might skip any of the medication, so it increases the patient compliance. These are known as fixed dose combination or single tablet regimens. According to WHO, when the CD4 cell count is below or equal to 350 cells per millimeter cube, the therapy should be started. Amtrocitabine and tenofovir is one of the very good medications. Tenofovir is the first line therapy for HIV infection. Along with amtrocitabine, the efficacy increases. WHO recommends two NRTIs plus an RT as the first line fixed dose combination, while the second line ART is the two NRTIs and a boosted PI with ritonavir in case when the first line agent has been filled. Now coming towards our main topic, that is amtricitabine with tenofovir. Amtricitabine is a fluorinated analog of lamivudine, while tenofovir is a nucleotide analog as available as a tenofovir disoproxil product with enhanced bioavailability. On the other hand, tenofovir alphanamide is a new product, tenofovir, which treats hepatitis B infection at a lower dose than tenofovir fumarate and is more safe at kidney levels because it do not cause reduction in kidney function. Amtricitabine and Tenofovir is considered as the first line and second line treatment for the individuals with HIV and hepatitis B virus co-infection. Now, what is the mechanism of action of the drugs? Antiretroviral drugs interfere with the ability of virus to multiply and reproduce. The NRTIs work by blocking the enzyme reverse transcriptase to form DNA from RNA. Now, DNA is not available to replicate, so it blocks the virus to make copies of itself. Now, what are the indications and uses of the therapy? These are used for the treatment of HIV-1 infection and HIV-1 pre-exposure prophylaxis. In pre-exposure prophylaxis, it is for the uninfected individuals having HIV-1 negative lab report who are at risk for HIV infection. They are also used for the treatment of hepatitis B virus. Now, what is the rational use of the therapy? These are used for the treatment of HIV-1 infection as well as for HIV-1 pre-exposure prophylaxis. Amtrocitabine alone cannot be used for hepatitis B virus, only can be used in combination. Tenofovir is the first line therapy for HIV infection, which is also active against hepatitis B virus. Both the drug work by slowing the spread of HIV in the body, although amtrocitabine and tenofovir will not cure HIV. These medications decrease the chance of developing AIDS and HIV related illness such as serious infections or cancer. What are the irrational uses of the therapy? Repeated exposure to amtrocitabine and tenofovir, the wrong selection of doses, so should be prescribed and recommended doses according to body weight, age, and creatinine clearance level. Taking it without prescription or without proper diagnosis or skipping the dose during a course may lead to resistance. Like if you stop taking tenofovir even for a short time or you start skipping dose, so the virus may become resistant to medications and it may be harder to treat. Now, what are the diagnostic and aggravating features? Increasing age, high viral load that is greater than 100,000 copies per ml, previous AIDS history. The previous AIDS history makes a person vulnerable to AIDS, further vulnerable to further prone to the HIV infection. Increasing alcohol and smoking increase the risk of disease progression, as these are the aggravating signs. The optimal time to initiate antiretroviral therapy in patients is when the CD4 cell counts is between 200 to 350 cells per millimeter cube. The combination therapy is always recommended. In patients who are asymptomatic, the assessment of the marker data like the RAP reports, T cell count, viral load measurements, medical conditions which are concurrently, and medication addiction history like morphine or cocaine. The results of resistance testing should be considered before initiating therapy. HIV is spread through the HIV partner, STIs, by sharing contaminated needles, blood transfusion, and during pregnancy or during breastfeeding. What is the brand name of an alternative? The Truvada is the brand name of amtricitabine and tenofovir disoproxil having the prescribed doses. Both are the NRTI drugs having a greater risk of kidney failure as well as the bone density loss. Descovy is another alternative and is safer because of the tenofovir alphanamide, as we have discussed, with the lesser dose that is 10 milligram or 25 milligram, and it is both are the NRTIs, and but having a advantage less bone loss and lesser kidney issues as compared to tenofovir disoproxil fumarate in Truvada. Currently, the preferred regimen according to WHO is Atripla, having a 2 VIDA plus efavirenz in the dose of 600 milligram. Efavirenz is an NNRTI and it is having only the long-term side effects, but is more expensive and more costly than the Truvada. Simdo is the combination drug of lamivudine plus tenofovir, and it is from the pharmacoeconomic point of view, it is less costly than Truvada. These are the alternative recommended antiretroviral agents. The Combivir is the combination drug of the zydovorin plus lamivudine. Absicom is the combination of the abacavir plus lamivudine. The and commonly prescribed antivirals are given like in among these zydovorin is safe in HIV positive pregnant women because of the less chance of infection to the baby. These are the separately prescribed brand names of the drugs, and common NRTIs in practice include abacavir, amtrocitabine, lamivudine, tenofovir, and zydovorin. Dosage of Emtricitabine with Tenofovir is the Truvada is recommended in the adults and adolescents weighing at least 17 to 35 kg weight, and Descovy is prescribed in the adults and pediatric patients weighing at least 25 to 35 kg body weight and creatinine clearance level greater or equal to 30 ml per minute. So, at least 4 weeks of therapy should be completed in both of the brands and both of the drugs. The drugs can cross the placenta, so should be avoided in pregnancy. No antidote are available for Emtricitabine and Tenofovir. So, in case of serious side effects, the patient must report the physician. Physician might switch the drugs with the safer replacement. Now, dosage adjustment in pediatrics and renal impairment. In pediatrics, according to body weight, the dosing of Truvada is recommended. So, this chart should be referred for the dosing of the pediatrics. Dosage adjustment in individuals with renal impairment, the creatinine clearance level greater than 50 ml per minute. So, Truvada is given once daily, while in the lesser than 50, that is 30 to 49 ml per minute, Truvada is given 2 Q 48 hours, and below 30 ml per minute it is not recommended. The side effects of the therapy: headache, diarrhea, nausea, rash, or GI complaints, that is nausea, diarrhea, vomiting, flatulence. These are the common side effects in the short term therapy. In long term therapy, the toxicity may appear like a reduction of renal functions, Fanconi syndrome, because of the therapy. So it should be used in caution with patients with renal dysfunction. Lactic acidosis, hepatomegaly with steatosis, and osteomalacia can be a long-term toxicity. And tenofovir can cross the placenta, so should be avoided in pregnancy. These are the drugs having a mechanism of toxicity. So the tenofovir enters the proximal tubule cell through basolateral organic anion transporter and exits through the apical transporter multi-drug resistance associated protein. So co-administered drugs like diadenosine, a substrate for OAT, and ritonavir, a substrate for MRP2s, can block these transporters, which increases the plasma concentration of tenofovir disoproxil fumarate by increasing the plasma concentration of tenofovir, so it can be hazardous to the patient. Tenofovir causes renal tubulopathy, which causes excessive calcium phosphate loss and causes effects of vitamin D, which might be leading to osteomalacia, that is bone softening. In long-term use, BMD and risk factors should be monitored, especially in those patients with history of osteoporosis. What are the drug interactions? Co-administration of 2-VADA with acyclovir and SIDS aminoglycosides, example gentamicin and gencyclovir, valacyclovir, should be avoided as these are eliminated by the active tubular secretion, which increases the concentration of amtricitabine and tenofovir. Lamivudine and amtricitabine has also the drug interaction, so should be avoided taking together. Cyclosporin, leflunomide, with having exposure to the tenofovir, so should be avoided taking together, while the should be avoided in pregnancy. Now coming towards our case study, that is the male person, 36 years old, is tested positive for HIV. He is feeling well, but he has reported 25 years smoking history and history of 5 years of alcohol. He is not a regular drinker. His physical examination showing no abdominal signs, and currently he has no abnormalities. White blood cells 78 cells, 700 cells per millimeter cube, HB 14 grams per deciliter. Creatinine clearance level 100 ml per minute, LFT normal, CD4 cell count 278 cells per millimeter cube, viral load 110,000 copies per ml. Abacavir did not found to be efficient and reported hypersensitivity, while tenofovir is found to be beneficial. Lab reports improved. Now, which combination therapy should be prescribed? Which antiretroviral regimen will you recommend later? Now, we have to prepare the SOAP note, subjective, objective, assessment, and plan. So, starting with the subjective. Chief complaint is HIV. HIV has been test-based positive. Age is the 36 years. Gender male. Elevating factors: smoking history and alcohol abuse. He is not a regular drinker now, but he is taking alcohol in intervals. That should be avoided also. History of medication: no such history is found, not prescribed in the case study, but he has shown the hypersensitivity to abacavir, so it's not used in therapy. Current medication is tenofovir, that is antiviral. Objective, the vital sign normal. Physical examination is no abnormalities found. Lab reports must be monitored. That is WBC 7800 cells per millimeter cube. That is normal. Hemoglobin 14 gram per deciliter cube. The HB for man is normally between 14 to 17 gram per deciliter. That is also the normal range. And creatinine level clearance is 100 ml per minute. That is also normal. CD4 cell count 278 cells per millimeter cube. That is the optimal time to start antiretroviral therapy. LFT is normal. Viral load 110,000 copies per ml. That is the aggravated limit. After treatment with tenofovir, his lab reports improved. Now, what is the assessment? HIV is tested positive and high viral load is clearly indicated the disease. Alcohol abuse and addiction were the aggravating factors. It usually speeds up the progression of HIV. Now, what is the plan? Check creatinine report again. So, because they start the therapy, the kidney function should be checked again. Medication is prescribed as a 2 by the 1 tablet QD, PO, with or without meals. Therapy should be continued for 4 weeks. Later will be the switch to the choice of regimen, that is the Emtricitabine plus tenofovir 300 milligram, that is 2 vada plus efavirenz 600 milligram PO once daily. Follow-up is after second week with the lab reports including CBCs, creatinine clearance level, LFT, and viral load test report. Patient should monitor his condition for in case of any emergency. He should visit a physician and report at once. The patient should be educated that he should stop taking alcohol completely and a patient should quit smoking. Avoid taking NSAIDs, aminoglycosides, as it will create drug-drug interactions with emtricitabine and tenofovir. Patient should be prescribed that he should take diet rich in calcium and vitamin D to overcome the side effects of the Truvada. Drug abuse and alcohol use can also directly damage the liver, increasing the risk for chronic liver disease. Like if the person smoke and have HIV, a person is more likely to get HIV related infections like cancer or serious infections, so smoking should be avoided. What is the goal of the therapy? Reducing the HIV viral load and to increase the CD4 plus cell count is the main goal of the therapy. Suppression of the viral replication usually leads to increased CD4 plus cell counts and which strengthens and boosts the immune system. Both the NRTI drugs inhibit the reverse transcriptase inhibitor enzyme required for the replication of HIV. Now we are comparing the medications common in practice and the recommended therapy. We have recommended the emtricitabine and tenofovir together, which emtricitabine is more efficacious, shown similar effects to the lamivudine and is effective at lowering the viral load and improving the liver disease, and which showing the synergistic effect in combination with tenofovir or efavirenz or with boosted PIs. And alone, the if the drug is given in monotherapy, that is the tenofovir is given in the monotherapy, so it will create after a time it will create a resistance. So should be given in combination to improve the efficacy. Abacavir has been reported a hypersensitivity reaction, so it avoided in the therapy. Lamivudine alone may become resistant. It's always used with the zadovudine in practice. And zadovudine is given always given in patient with CD4 plus T cell count lesser than 200 cells per millimeter cube, and hematological toxicity is reported in asymptomatic patient, so it should be avoided in the asymptomatic patient. It's always referred to the symptomatic patients. Adverse effect, as we have discussed already, headache, nausea, diarrhea, and dose adjustment is in case of written clearance is if altered. Drug interaction is with the NSAID aminoglycoside, so should be avoided taking NSAIDs. What is the summary of the whole topic? The skipping dose could lead to resistance and further complications. In case of serious side effects, the patient should report their physician, and physician could change the regimen and may go for second line agent. As we have discussed, the and two NRTIs and plus boosted PI can be taken as the second line agent if the first line agent failed. After starting a therapy, one should keep in mind the benefits and risk of adverse effects for it. Patient surrogate marker data, that is the CD4 plus cell count lesser than 350 cells per millimeter cube and viral load greater than 100,000 copies per ml is the aggravating sign that to start the antiretroviral therapy. Therapy should suppress viral replication as soon as possible and should be monitored by lab reports in 1 or 2 weeks interval to get the patient present report. Now, these are the references which I have used for the proper understanding of my drugs. Hope you liked my presentation. Thank you.